Good afternoon, everybody. Welcome to another interview. I'm Peter Duffy. As usual, I'm joined by Helen Hughes, the Chief Executive of Patient Safety Learning. And today we've got Chelcie Jewitt, who is joining us, who is, I think, well known for being the co-founder, I think I'm right, of Surviving in Scrubs. So welcome, Chelcie. Thank you very much for taking the time to speak to us. Could we maybe start if you could just take us through your own personal experiences and what it was perhaps that led you up to starting the Scrubs campaign?
Yeah, sure. So, just as a bit of background. So now clinically, I work as an emergency medicine and intensive care medicine um, resident doctor up in Merseyside. But it took quite a little while for me to decide on what specialties I wanted to do. With emergency medicine being kind of like my parents' specialty as it was. So within kind of like post foundation and F3, 4, 5 years, I kind of did a bit of career exploration and tried to decide what I wanted to do. And a big part of why I felt like I needed to do that was because at that point I'd been told multiple times that emergency medicine wasn't for women and it wasn't female friendly. And if I'd wanted a family, etc., that I couldn't do, I shouldn't do emergency medicine. So that journey in itself was kind of sparked by sexist comments. And I eventually had this one experience where I was belittled in quite a public forum. I was belittled in quite a gendered manner, in quite a sexist manner, in front of a really packed MDT room, and that kind of just sparked in me this like real kind of emotional response. I'd I was post nights when it happened, so I felt really belittled. I felt humiliated, and I really struggled with that sensation, and I put a lot of blame on myself about how my response to having that happen to me was, my fault. I was emotional. I was taking it seriously. I must be the problem. But then I went away and I had a week of leave, and during that week of annual leave, I'd actually started reading Laura Bates's book, Everyday Sexism. And it was through reading that book that I realized that I had been a victim of sexism at work. And then I then started doing a piece of work myself, looking into sexism within healthcare and the experiences of female doctors compared to male doctors. And that small, in no way, shape, or form, statistically significant piece of work that I did, I presented at the Medical Women's Federation conference, which was joint with the BMA back in November 2018. And the BMA kind of ran with that piece of work that I did, and that resulted in the Sexism in Medicine report that was published in August 21. And with doing that piece of work, that was very much kind of where my headspace was at the time. I was thinking about the times that I'd been, humiliated, belittled, hadn't been given the training opportunities that my male counterparts had been given, had been assumed to not want to go to theatre. It had been assumed I didn't want to do the practical procedures. It was assumed I was very good at doing the number crunching and the data collection, but heaven forbid I actually present at a conference. And that was kind of the experience I'd had and the conversations that were being had at the time. But then the BMA asked questions about sexual misconduct. That kind of term wasn't used. It wasn't really as commonly heard of as it is now. But they asked questions about unwanted verbal conduct and unwanted physical conduct. So essentially, those terms um, substitute for sexual assault and sexual harassment. And we found with the BMA survey that, huge numbers of female doctors were experiencing these behaviours at work. And it was through
Mm.
reading the open answer questions that I then realised, oh, I've been sexually harassed at work. Oh, I've been sexually assaulted at work. because we really normalise this. We really
Yes.
normalise this.
And the figures are quite shocking, aren't they? I seem to remember it's about a third of female doctors have had some sort of unwanted physical contact just in the last couple of years.
Yeah, yeah. So
So this is not historical stuff either.
no, it wasn't. And so the survey was like the questions asked for the 2 years prior to that survey going out. So fairly, fairly contemporaneous data. And then I'd had this realization that that's what I'd experienced. And there'd been a bit more work going on at the time. The Royal College of Surgeons had done a report, had written an article around sexual assault in surgery. There'd been the gender pay gap review that Professor Dame Jane Dacre had chaired. And it sort of felt like things were happening, people were talking about this. And then all of a sudden there was this radio silence. But during that time, the other half of Surviving in Scrubs, Dr. Becky Cox got in contact with me, and Becky and I, so she's an academic GP by background, working down in Oxford. We basically formed an informal peer support group. And we shared our stories, our experiences of what we've been through, how it made us feel, and then we eventually met in person. So this was still around COVID, so we did a lot of talking on Zoom and other virtual ways of contacting each other. And then we finally met in person in Birmingham, and we decided that we needed to do something, and that's kind of where Surviving in Scrubs has come from.
Mhm.
So Surviving in Scrubs at our core, and how we started off, is our website. Bearing in mind, Becky and I aren't very techie. We're not very good at IT. So we've made this website, and essentially we just wanted anyone who works in healthcare, so not just doctors, but anyone, any gender, any profession, any specialty, anywhere within the country, to tell us their experiences of sexual misconduct at work. So anything from sexist comments, jokes, behaviours, attitudes, all the way through to that more violent end of the spectrum, the harassment, the assaults, etc. And we've got we've got 235 testimonies on there now.
Mm.
So huge numbers, and actually some of them, some are quite short and only a couple of sentences long, whereas some are pages long almost, because so
Yes.
many things happen to that one person.
Yes.
And that real collective narrative has been so powerful and has enabled us as a campaign organisation to really drive forward policy change at a national level. So yeah, that's
Yes.
kind of the background as
Yes.
to who we are and where we've come from.
Yeah, Helen and I were talking just earlier before you joined us about some of those accounts on your website, and they really are quite shocking, some of them.
Yeah.
As a surgeon myself until fairly recently, I really just did not think that sort of thing would go on. I was really quite shocked, and I would actually encourage anybody who watches this to go to your website and read some of those accounts, because I think particularly if you are a male, and often these things are not observed by other males, it's really disgraceful. It's really shocking. So congratulations really on setting up such an informative website. For somebody who you say you're not terribly into IT, it looked extremely professional to me. So sorry,
It's
Helen.
very,
Yes.
it's very accessible, the stories, and I was
Yes.
reviewing them in anticipation of today's conversation, Chelcie, and what shocked me, not only that they are very contemporaneous, and you think in this day and age this shouldn't be happening, we should all be aware of this, behaviours shouldn't be tolerated, and I'll come back to that in a second, maybe with a question, but it was the long-term impact of it. There was one particularly, a woman that was still blaming herself for not responding in the way that she felt that she ought to have done 42 years after a kind of serious sort of misconduct, sexual misconduct, and that it's clearly blighted her her personal and her professional life in all that time. And that's it was horrifying to read that, and as you say, the sense that it's still happening now. Peter, can I jump in with a question which is not one of the ones we'd prepared, which is often the way. But Chelcie, I mean, when you were a sort of a student, were you given, or your colleagues given, kind of guidance around behaviours and what was acceptable and not, and what to do about it if it happened to you? Or was this something that was just an invisible issue?
It definitely wasn't spoken about when I was at university, but I think unfortunately I went to university quite a while ago now. So I started in 2010 and graduated in 2015. But I think that's a really good point. And actually, so as a campaign, we're currently teaming up with the BMA again, and we're asking similar questions in that survey that I did a few years ago to medical students, because more work has been done in this area, and we know a lot more about the hierarchy, and we know that medical students are particularly vulnerable to experience instances of sexual misconduct, either in the university kind of setting, but also when they're out on placement. And the difficulty is when they're out on placement, they slip through the gaps in terms of support and who kind of looks after them, so it were. But I think what I think is really interesting is about when it comes to what do we do, who do we talk to, those kind of conversations are really hard to have, not only in terms of like logistically, like who do you go to, who is that person that you're meant to talk to, because I think I had like some form of supervisor at university, but I can honestly say I think that person changed like 3 or 4 times, and I think I only met them once. So it's really hard to know the logistics of those side of things, but also how to have these conversations. It's really, really difficult because they're awkward, they're very emotive, and it's, we have so many conversations, we have so many communication skills, training sessions when it comes to talking to patients and to giving patients terrible news and, dealing with their emotions. But actually, we don't have any training in how to communicate with our peers and with our, with the people that we work with. And I think that's a real area of work that needs to be done, and has definitely been highlighted the more that like we now go out and we do a lot of training and education, and we always get those kind of questions of like, well, what do I do? How do I deal with that? Because no one has spoken about it before. So it's new to everyone. So it's it's really difficult.
And one of the things that came out, and you mentioned this yourself when we were talking about your experiences, was the sense of guilt that some people have when they experience sexism or misogyny, which again is awful, because why on earth should the victim end up being essentially guilt tripped like this? So yeah, it does seem to be something that if medical schools hadn't got this on their curriculum, it does need to be pretty urgently addressed. And it's good to hear that the BMA are on board with this as well.
One thing I'd spotted in some of the stories, Peter, was the vulnerability of students, people in training, and that the very person that is your supervisor, who has a power position about your future career and future placements, if that person is the one that's the perpetrator, then as you say, Chelcie, where do you go? Because it's as much about power as anything else. So I don't, have you had responses back from, you say influencing policy, but is anyone working on this in terms of giving guidance to, I don't know, HR people, clinical leads, university tutors? I don't know. I mean, do you know if anyone's doing that work to help with well, what do I do now?
Yeah, so NHS England have published kind of like a gold standard framework in terms of what to do from a HR perspective, what the reporting processes should look like within, within NHS organisations. My understanding is I think every trust in England has signed up, maybe every ICB as well. So, people have, these organisations have signed up to these things. It's now seeing how that happens and takes effect. So we, again, we as an organisation did work quite closely with NHS England to help produce their framework, and we are pretty happy that we've tried to get as much of the kind of survivor perspective in there. We're aware that as survivors, we're very rarely included in these conversations because people take quite a organizations take quite a paternalistic approach and think they need to do what's best for us. But actually, that's not right. And we need to have that survivor perspective there to give back as much autonomy and as much power to those individuals who've had their dignity violated. So that's kind of what we want to focus with that. So there is frameworks there, but as I say, at the moment, we need to wait and see how these are brought into organisations, because my understanding is there isn't any kind of sanction for organisations that don't actually do these things and do them appropriately. So that's something that we're kind of pushing for. But also, we as an organisation have now developed over these past few years, and we now also go into organisations. We've been all over the country delivering CPD accredited education and training relating to how to manage a first disclosure, what to do in terms of being survivor focused when it comes to keeping them safe, changing culture, allyship, and all those things as well. So there is definitely work going on out there. It is early days, but I'm hopeful that this is a fairly high up on organisations' agenda. So I'm hoping to see some real changes happen over these next few months, few years.
When I was a trainee, you barely ever saw a female surgeon, but there are plenty of them now. They're still obviously in the minority. But I kind of assumed that these old attitudes and prejudices and so on had died out, but obviously clearly not. Do you think that these things have at least improved, or do you think the current generation are really just as bad as the old dinosaurs like me?
I think that's a really interesting question. And I think in light of recent kind of like media interest around misogyny and around social media, I'm obviously alluding to Adolescence that was on Netflix.
Yes.
I think there's generational differences. For example, I have heard from older colleagues how women shouldn't be doctors, for example. I don't often hear that from people, my peers or my juniors. But I do think that misogyny and sexism is still here. I think it's a bit more, subtle now, and I think it's harder to call it out, but equally, I do feel as though people are speaking about this more, both men and women. So on balance, it's different, but it's still there. Things are getting better in some aspects. We do have a lot more females in the medical profession. We have a lot more women in leadership positions, but the balance isn't there yet. It's still very heavily skewed towards men in these positions of power. So again, it's a conversation that I think people have had these conversations about sexism, etc., forever and ever and ever, but it's been out in the open within healthcare and the medical field for what, 8, 9, maybe 10 years, probably not even that. So again, that's a fairly young conversation, because this is talking about culture, and culture is the hardest thing to change.
Yes.
So yeah.
And moving on to culture, obviously the angle that Helen and I are coming from is patient safety. So this kind of toxic culture, obviously, it spills over into whistleblowing issues as well, which is my particular interest. Um, Obviously, the kind of attitudes that you describe have a major effect on the doctors who are the victims. But presumably, it also has a significant effect on patient safety too. Can you just talk us through that?
Yeah, absolutely. So the first thing I will say is I think there's some work coming out of the University of Glasgow, and I think Professor Rossell is doing quite a lot of work around this, looking at how these behaviours directly impact patient care. So I don't think there's much in terms of, that direct impact in terms of research out there. We don't have that evidence as such. But we know that the effects of these behaviours lead to individuals decreasing their level of productivity. They are less, they're less likely to want to come to work. They're less likely to go above and beyond because they are distracted by this fear of what might happen to them again because of what's happened to them before. And we can assume that that does affect patient care. We also know, and I've also had a personal experience, that very often, or a recurring theme that we see is that female clinicians very often have their plans ignored or questioned and or discredited because purely on the basis of that being a female clinician, whereas if a male clinician gives the exact same plan, that plan gets instigated immediately. So there is also this kind of element coming through of a delay to patient care because of this assumed lack of competence regarding female clinicians as well. So that is another area where we think patient care is affected. And it's not really within our remit as our organisation, because we very much focus in terms of interprofessional sexual misconduct. But again, if you look in kind of mainstream media, there's this real push at the moment talking about women's health and health inequalities. So that kind of sexist, misogynistic way that we have always learned medicine, because all patients seem to fit the mold of white males. We know that drugs don't necessarily work as well as women don't present in the way that we've been taught. So there's also that kind of element of how that affects patient care and patient safety as well. It's really eye-opening when you start looking at these things from this kind of like critical perspective of how different that experience is for men versus women, either as a patient or as a staff member within healthcare.
Can I just mention that, I mean, you're absolutely right, Chelcie, and people that want to know a little bit more about it, we have a free knowledge sharing platform, the Hub. We have a lot of content on there about particular kind of, sort of underdiagnosis or lack of access to treatment that are quite gendered, so that it's very significant. It's not just around obs and gynae services, it's a whole range of other ones. So people that do want to follow that up, there will be content on the Hub for that. But I just wanted to pick up something that you mentioned actually at the very beginning about being a member of a multidisciplinary team and the impact that it has, because we know from research that you're likely to get much better quality of care and outcomes and reduced harm from avoidable harm if you've got an effective multidisciplinary team. And you mentioned at the beginning, I think, about the challenges of the cohesiveness of a multidisciplinary team when this kind of behaviour goes on. So just and I just wondering if you'd want to reflect on that, because I spotted a few of that theme in some of your stories about people raising something with the team members and the team members not knowing how to deal with it and kind of just blanking it, really. So people feeling very professionally vulnerable even within a team of caring professionals.
Yeah, I think that fits with this theme of power and the hierarchy within healthcare. So even if we have fairly flat hierarchies in whatever teams that we work in, it still is quite difficult to speak up, especially when there is a culture of tolerance within that healthcare team. So if you are the first person to speak up against something, it's really, really difficult to do that. But as soon as one person's done it, more and more people can do it. So it is just kind of like breaking that barrier. And, you know, that fits that fits in with power dynamics, with hierarchy. It fits in with leadership, with followership. It fits in with civility as well, and basically respecting each other. And that can be difficult to do at times when we are stressed and we're overworked, etc. You know, but that shouldn't feed into how we interact with one another, because we're all in it together, and it's all rubbish because it's really hard to work in the NHS. It's great, but it's also very hard. So it's having that appreciation for everyone being individual, everyone being people, everyone having the same right to have their boundaries respected, and, you know, to, it seems really silly, doesn't it? But everyone has the same right to come to work and not be a victim of sexual misconduct.
Yes, and to offer your opinions, because that very much makes me think about the MDT meetings I've been in. And while you were talking, I was thinking back, and I see those trends there where so often they're dominated by sort of big male personalities, and the female attendees just don't get a look in. And that's, apart from the rudeness of it, that's a huge loss of information that it might well be vital to patient care. And I have to confess, I suppose I've grown up in that kind of world. And looking back, I suppose I just kind of accepted it, but it certainly was there. It's awful that it's just become the norm, really.
Yeah, and people don't know what they don't know. So if it is kind of what, if no one is speaking up and no one is challenging the status quo, you're not going to know what you're missing out on, are you?
No.
And this is how I frame it to people when they get really scared about speaking up and, you know, say things like, oh, well, I don't want to make a fuss. It was just a little comment. It was just a little joke. No, actually, those little comments, those little jokes, they need to be called out and spoken about, because people need to realize that what they're saying, the behaviors they're perpetrating, the attitudes that they're perpetrating aren't acceptable. And then they need to be given that opportunity to change. And doing it at these low level microaggressions is a lot easier than someone, you know, escalating their behavior, because they're pushing boundaries, they're not getting any pushback, so they think it's accepted, it's okay, it's tolerated, and then they end up sexually assaulting someone. At that point, that is extremely difficult to speak up about, whether you are a victim of that or a witness to that. But if you can do these conversations early on, it gives them the opportunity to change, and that helps with the culture as well.
Can I also follow up for that, which is have you engaged with the professional regulators, and what is their response to this, and whether you think more is needed?
Yep. So we have we've got very close links with the GMC, and I think that's probably to do with the fact that Becky and I are both doctors, and they're very supportive of the work that we're doing, and they are bringing in changes, albeit probably not as quickly as we would like, but they've also, you know, kind of got us involved with some education, some training. We've delivered some talks to them. We've had meetings with Charlie Massey and other you know, key figures in that organisation. We've also had a meeting with the chairs of all the regulators of all healthcare professions, and we've been, again, pushing forwards with them, but unfortunately not really hearing much back, which is a shame. I think that's a real shame, because I just think I feel like the regulators have such a key role in providing accountability and, you know, setting that standard of what is and isn't acceptable for a profession to do. So our first campaign was to write to the GMC about their rewording of good medical practice, because the old version, the 2013 version, essentially said that all doctors will respect their colleagues, which is such a beige, blasé statement that it's just pointless. it's just a bit pointless. How do you measure that? So we wrote to them saying that we wanted a clause in the new rewording to basically say that doctors won't sexually harass or sexually assault their colleagues. And it's terrible that you have to spell that out in black and white for medical professionals. It really, really, really is. But that's in there now. So that's the standard that people are held to account for. So we now need to see people being held to account for it. And I'm aware that the regulators themselves, I don't think, don't perform the tribunals. That goes out to the NPTS. That is where we also need to see a bit more work in terms of a standardization of how sanctions and restrictions, etc., to practice are going to occur. And at the moment, it's really early days and we haven't seen much. But we are, as part of one of our kind of research projects, is we are looking at the data that they're publishing around that to see if we can see some trends as well and stuff. But watch this space and we'll see what happens.
My next question was going to be, I mean, we've talked quite a lot about the medical profession here, haven't we?
Yeah.
And we've talked about the fact that there are more and more female doctors. I think you're nearly up to parity. Have I got that right?
I believe there are now more females on the medical register than men. I think that happened last month.
Right. Oh, well, there we go. However, when you look across the whole of the healthcare world, of course, it is females who are sort of dominant in terms of the numbers. We look at the nursing staff and the other allied professions. And in a sense, they're probably even more vulnerable, aren't they? Because they don't have that same position in the hierarchy. So are you doing anything with other healthcare professionals to sort of share your learning from this? And I'm thinking in particular of things like the NMC and so on.
We're trying really hard to engage the NMC. I had a meeting with them a couple of months ago, and essentially the person who I spoke to said that this is not high on the NMC's agenda currently, which for us is obviously a real shame, because this is our agenda. We want to ensure that anyone who works in healthcare has a safe workspace, so they can thrive and work to the best of their abilities. But yeah, unfortunately, when we spoke to the NMC, they weren't very keen to go forwards with working with us and collaborating on some kind of project.
I might be able to help. I might be able to help with it. The Professional Standards Authority, who is the regulator of all the regulators, they're doing a lot of work with the NMC, and there's an oversight committee to make sure that they are addressing the big cultural issues that they've experienced that are quite well known, predominantly racism, and they have a new interim CEO that's only been in post a few weeks, and I'm sure he'd be rather shocked and would be very open to that conversation. So I would go back again and I can give you his contact details.
Oh, that'd be amazing. We've also had meetings with the PSA around quite a few different things. So basically, we're just trying to engage anyone and everyone. We're aware that Becky and I, who are, we're the founders of this organisation, we're aware that we're doctors, but we work within healthcare, and we realise that this isn't just a doctor problem. That and that was a real big driver of us starting Surviving in Scrubs. And that, that's some people always think like, why have you called yourself Surviving in Scrubs? But we came out of the pandemic. We were formed during the pandemic when everyone was wearing scrubs. So to us, it's a real unifying symbol, because you'd walk onto a ward and you'd have no idea who the pharmacist was, who the nurse was, who the doctor was, who the HCA was, because everyone was wearing scrubs. So that is kind of where we've come from, and we just want to get as much engagement in this as possible from any kind of background, really. So if anyone listening or watching kind of wants to get involved, please just email us, and we'd be happy to see what we can do, because we do now have a group of volunteers behind us from different backgrounds. So predominantly medicine and medical students, but we've also got some paramedics as well, and a few other allied health professions. So we're just really keen to get as much representation here as possible to open this conversation out to as many people as possible as well.
And can I pick up on that,
yes,
Peter?
yes.
Because we talk specifically about kind of gender imbalance and sexual misconduct, particularly male to female. Are you getting approached by members of the LGBT plus community? Is this something that is kind of, because it's a broader issue about power imbalances and you know, behaviours that are unacceptable? Are people coming to you with their perspectives on that?
That's a really good point, and that's something that we've reflected on as an organisation. So we have now changed our submission form so that people can tell us a bit about their other protected characteristics in terms of these issues. We don't publish that data, that's just kept aside so we can kind of see any trends or kind of areas that need to be worked on. At present, the data that's out there in terms of sexual misconduct within healthcare is very it's focused by gender, and it's focused by a kind of specialty or professional background. But actually, we know from, you know, society as a whole that individuals who have one or more protected characteristic are more likely to experience sexual misconduct. So this intersectionality aspect is something that we're, again, really keen to explore. And we've had a couple of other organisations get in contact with us, and we're trying to do pieces of work here and there. So again, you know, we'd really like to open up this conversation. So if anyone would want to come and specifically give that kind of LGBTQ plus perspective on all of this, that would be really interesting as well.
And we're probably into our last few minutes now of the interview, Chelcie. There'll be people watching this or who will watch us in the future who will be going through exactly the sort of traumas that you've described. And who obviously will be struggling with how to deal with that. What sort of advice would you give someone who is on the receiving end of, you know, unwanted advances or inappropriate comments? How should they deal with it?
The first thing I'd say is to, first of all, just allow yourself to feel your feelings. I think we've already touched on the fact that some people can be made to feel guilty or feel ashamed, but if you're upset, be upset. If you're angry, be angry. You know, just feel those feelings and give yourself that time and that space to do that. The second thing I'd say is don't suffer in silence. Try not to be alone. You don't have to go down a formal reporting process, but you can talk to someone and just tell them that something's happened to you, or you're not happy, or you're not sure that what you experienced was okay or wasn't okay. Can I just sound it out? That kind of conversation. You know, you don't have to go all guns blazing and making a formal complaint. If you do feel as though it warrants you to make a formal complaint, you feel as though you are able to, you feel psychologically safe enough to do that, every organisation in England should have a sexual misconduct policy. If people are listening or watching outside of England, then get in contact with your HR department, and they should have a policy either within bullying and harassment, or they may have a sexual misconduct policy as well. So we're very aware as an organisation that sexual misconduct should definitely have its own policy, because it comes with other psychological difficulties that bullying on its own or harassment on its own doesn't. But if that's all you've got, you kind of got to, you know, work with what you have. And I'd advise people, if they do want to go down that formal complaint process, to try and find an ally, whether that is just a peer or a friend or a supervisor, just so they're not alone throughout that process as well. But in terms of what else they can do, you can log on to our website. We've got some resources on there. You can always contact us, and we'll do our best to respond within a couple of days. that sometimes is a little bit longer than a couple of days because we're all over the place, and I do work nights still working in A&E, but we do our best to get in contact with people ASAP. We are also in the process of collaborating with Doctors in Distress, and we are running listening groups once a month. So these are online via Zoom. You sign up, and essentially you don't have to put your camera on, you don't have to name yourself, but you can either listen to other people just to know that you're not alone, or you can talk to other people to ask for advice or just to talk about how you feel. And I think a lot of this, I know from my past experiences, I haven't always needed to go down that formal report process. I've just needed to have a bit of a sounding board and for someone to say that what happened to me wasn't okay. And that is very much what that listening group can do. It can deliver that kind of support.
Thank you so much. I mean, particularly it's what emergency medicine and ICU that you're doing, and trying to take all this on as well. That's quite a workload. Yeah. So thank you for clearing the time to speak to us today.
Oh, no, it's fine. I've enjoyed myself. Thanks for having me.
Good. No, it's been an absolute pleasure. Thank you so much. And yeah, hopefully we'll be back with another interview very shortly.